We are at 87.
Chris, I sent you a message. I think we might have to start now. It's 4 o'clock. Yeah. Okay. Good afternoon, good evening, good morning, whatever part of the world that you are in. My name is Yomi Ajayi, and on behalf of the Society of Gynecology and Obstetrics of Nigeria, the ESGE Working Group on Non-Surgical Ablative Therapy of Benign Uterine Diseases, and the International Society of Minimally Invasive and Virtual Surgery, I welcome you to this webinar themed Non-Surgical Treatment of Benign Uterine Disorders. We're dealing mainly with fibroids and adenomyosis. And I'm happy to say that we have a very rich and experienced panel to do justice to this topic today. We are waiting for the Sogon president to start things up, but if he does not join us on time, we just go on and we take some words of encouragement from the society. So we also have Professor Hugo Verhoeven, who is the medical director of the Private Center for Endocrinology, Reproductive and Preventive Medicine, Düsseldorf, Germany. He's also the chairman of the ESGE, that is the European Society for Gynaecological Endoscopy, working group on non-surgical ablative therapy of benign uterine diseases. We have Professor Christopher Aumakhu, who is a professor of obstetrics and gynecology of the University College Hospital, Ibadan. He's presently the Secretary General of the Society for Gynecology and Obstetrics of Nigeria, SOGON. And we have Dr. Ahmed Ninalowo. Dr. Ahmed is a trained vascular and interventional radiologist with subspecialty training in interventional oncology. He has special interest in minimally invasive oncology treatment and fibroid diseases, and has a passion for improving access to minimally invasive therapies in the West African population. And finally, we have Dr. Nuria Pons Serra. Dr. Nuria is a medical doctor at the University Hospital Mutua Terrassa in Barcelona, Spain. I think it's called Barcelona. She's a specialist in advanced laparoscopic surgery, family planning, and sexology. She's a member of the Haifu unit of the University Hospital Mutua Terrassa in Barcelona since 2017. So Dr. Nuria has quite a vast experience in Hifu. And she's a member of the ESGE, the European Society for Gynaecological Endoscopy working group on non-surgical ablative therapy of benign uterine diseases. So I promise that you're going to have a very interesting session today. And as usual, anytime we talk about fibroids in this part of the world, there's a lot of interest. So right now we have over 300 people that are already joined us on this webinar. And so I promise that you're going to have a wonderful time. And you can always ask your questions on the Q&A session. We'll take as many as we can take. And I also like to tell you that we're also broadcasting live on Facebook. So at this point, since we have not been able, the president is yet to join us, I think I'll just say a few words on behalf of the society. And it's a pleasure to welcome everybody to this webinar. I'm speaking on behalf of the president, and it's anytime that we talk about fibroids, since the first description of uterine fibroids in 1793 by Matthew Bailey, a lot of interest has been woken up especially in this part of the world, because that we know that race is one of the risk factors for uterine fibroids. And recently also we are beginning to learn that when we thought initially that blacks were precluded from adenomyosis, that actually was a mistake. And so we're going to have a lot of things to talk about today. And without so much ado, I'll thank all the societies that have come together to put this together today. And we definitely are going to have a wonderful learning experience. Well, we are over 369 now that have joined, so we expect to get more people joining us. So without much ado, I just call on Professor Hugo Verhoeven to tell us about non-surgical ablative therapy for benign diseases of the uterine wall. So Hugo, the floor is yours. Thank you so much.
Just 1 second. We'll start immediately. Kan we speak here again? Good afternoon, ladies and gentlemen. Mr. Chairman, thank you very much for the very nice introduction. I've never been to Nigeria. That's one of the few countries I haven't been, but well, we'll see what's happening with your Haifu Center in Lagos or in Abuja, and I'm looking forward to come to see you. I bring you the greetings of the European Academy of Gynaecological Endoscopy. En, Jürgen, das geht nicht. Okay. And as the chairman said before, I am at the moment the chairman of the ESGE working group on non-surgical ablative therapy of benign uterine disease. It was not very easy to have the ESGE so far that they were ready to open a working group on non-surgical ablative therapy because they were not very interested. So we needed to work quite long with them, and now we are very happy. There are only 3 working groups at the moment in the ESGE, that we are one of the leading ones. As the chairman said, I'm working mainly in Düsseldorf in Germany, but I try to be active a little bit all over the world. The topic of today is non-surgical ablative therapy for benign disease of the uterine wall. I have nothing to disclose, but I would like to thank immediately, before I start, Mr. Peng from the Haifu company in China for his logistical support. Without him, everything would have been much, much, much more difficult, and I thank him very much. So, if we talk about Haifu, Haifu stands for High Intensity Focused Ultrasound, and it is not a new technology at all. But unfortunately, most of the gynecologists have never heard of Haifu. On the other hand, the dermatologists, the cosmetic surgeons, the urologists are quite using this technique quite common. So Haifu is a non-invasive technology providing an alternative or a complement to surgery, radiation, and medication. And when I was looking through the literature, I wondered very much that more than 100 indications of Haifu are under investigation. And I show you here an overview of all the indications for Haifu. Of course, we are not going to talk today about the cardiovascular or the endocrine or the gastrointestinal indications. We are going to concentrate on the oncological indications. And as you can see there very clearly, Haifu is used for the treatment of bone metastasis, prostate cancer, breast cancer, kidney cancer, liver cancer, of course, pancreatic cancer. Yeah. Today, we're not going to talk about that, and we're going to concentrate on the indications in women's health. And as you can see there, 2 of the main indications for Haifu are fibroids and adenomyosis. Besides of that, also breast cancer and breast fibroadenomas. We are going to talk today only on fibroids and adenomyosis. Small story, about 2.5 years ago, I went to a meeting in Surabaya, and my dear friend Peng tried to introduce me to 3 very good friends of mine. On the right side, you see Professor Shilong Li of Taiwan. Next to him, Professor Felix Wong of Hong Kong. And then next to him, Professor K.Y. Lee from Singapore. And the two guys in the middle tried to convince me to come to their lectures because they had something sensationally new in the treatment of fibroids. So I decided to go to their lectures, and I must really say it. I said something like, wow, that's interesting. And I was asking myself why this technique was only known in Asia, especially in China, but also in Hong Kong and in Taiwan, but practically not outside of Asia. So I decided to try to make this sensational technique popular also in Europe. And we started working, Beng and myself, and already after 6 months, we had the pleasure to have our first symposium in Vienna, together with Professor Gill, standing next to Professor K.Y. Lee and then myself. And we thought that Vienna would be a very good spot for establishing a Haifu center and to go from there to East Europe and of course also West Europe. So this symposium was a small one. We had only 100 people listen to us. Our next spot that we decided to be important to us was Dubai, because if we would have a center in Dubai, we could from there expand to the complete Middle East. And indeed, we set together Professor Reyes Devasi from Dubai, Rosik Singh from Chongqing, and Professor Rudy de Wilde and myself. And we tried to set up the center in Dubai. That's all a little bit more difficult as we thought, so we are working on it. So what is ultrasound-guided Hifu ablation? I'll start with a 3-minute video because a video says in 3 minutes much more as an explication in a whole hour. There we go.
An ultrasound beam can be brought to a tight focus at a distance from its source, with sufficient energy concentrated within the focus. The cells lying within will be killed without damaging the surrounding tissues. High Intensity Focused Ultrasound, Hifu, is, therefore, a non-invasive method of producing selective and trackless destruction of deeply seated tissue targets within the body, without causing any damage to the overlying surrounding tissues. Ultrasound-guided Hifu involves Hifu ablation under the guidance of real-time ultrasound imaging, which can achieve an uninterrupted visualization of tissue coagulative necrosis during the treatment via grayscale changes in real time. The ablated lesions demonstrate an echogenicity or grayscale changes in the ultrasound images after the sonication, which enables immediate assessment of patient's response to ablation, ensuring a safer and more controllable therapy. Imaging fusion and 3-dimension digital reconstruction function provide doctors with a much clearer vision during the whole procedure. Thus, doctors can finish the treatment with an ease. Ultrasound-guided Hifu, a new option for the gynecologist to manage uterine fibroids and other gynecological benign tumors, can maximally preserving the integrity of the uterus. No surgery, no bleeding, and no anesthesia. Patients can even chat with doctors during treatment to ease their tension. Patients can go home in nearly 2 hours after the treatment and resume normal life the second day after treatment.
This video, I think, gave you a nice overview or a nice introduction to Hifu. So principles of Hifu ablation, I just read what is listed here. We have a transducer, and the transducer of the Hifu system converts electric energy into acoustic energy. So the ultrasound emitted by the transducer is focused and focused only on the target tissue. The temperature at the focal region reaches 65 to 70 degrees, and an irreversible necrosis is induced. Hifu ablation is performed, as said before, under real-time ultrasound, and either with ultrasound or MRI. We are going to talk today on ultrasound Hifu. Once again, the transducer is focusing the beams on the target tissue, and that small spot of, let's say, 1 to 3 millimeters can be destroyed selectively without damaging the surrounding tissue. This is very important because at the beginning, Hifu is not that easy. So even if you went to Chongqing for 6 months or 3 months or whatever, if you go back to your own city and you're sitting there in front of your working table, you can have circumstances where you don't know anymore what to do. So there it's always very important that you have some support from the mother in Chongqing. So we see here the support center connected with all people in the world doing Hifu treatments, and they are always ready to support and maybe later also to take over the procedure when you are in trouble. So there are 3 systems available for Hifu ablation. There is the GE system, the Philips system. They are both MRI guided. And then, of course, the Chongqing Hifu system, that is the only one who is ultrasound guided. Very important slides. What are the advantages of Hifu ablations? We have the clinical advantages and the social advantages. And I speak very slowly because this slide is very important. So we have no surgery. That means we have no incisions, we have practically no hospital stay, and we have no bleeding. No general anesthesia, conscious sedation. There is practically no damage of the surrounding tissue. The patient has minimal discomfort, and very important for future pregnancies, the uterine function is mostly preserved. But there are also social advantages. The minimal recovery time. People can go back to work much quicker. They can exercise. They can enter into their daily routine. They have an improved quality of life. And of course, for the medical systems or the medical insurances, the costs are much less. This you saw before. It is important that we do those procedures in a normal room, not in an OR. And every gynecologist can do this procedure without help of the radiologist, because you don't need the radiologist. And as stated in the video, you see that on the right side, the doctors who are doing the surgery are looking only at screens. And next to the screens, there is the patient laying on her belly, and she's in conscious sedation, but so that she still can talk to the doctors and say when it hurts, so that the doctors can adapt the treatments. So on the left side, you see only the patient, and a nurse. And on the right side, the so-called surgeons. Once again, one normal, regular room. If you want to start doing Hifu treatments, it is very important that we realize that we need basic, maybe even advanced knowledge of MRI, of ultrasound and real-time ultrasound, and we need to have a perfect knowledge of the anatomy of the region we want to treat. We need to understand how Hifu works, and we need to be able to give an interpretation of what we do with Hifu. So this is nothing what you're gonna do in 5 minutes. We are talking today about the benign indications for Hifu, and we are concentrating on uterine fibroids and adenomyosis. Fibroids are the major indication for Hifu, and it is amazing that we have a registry now of 137,766 Hifu treatments. So that's quite a lot. We are sure that the procedure is safe. And since 2019, the National Institute for Health and Care Excellence in the UK decided to develop and to publish guidelines for the treatment of Hifu for fibroids. This is very important. This complete protocol, this paper is about 90 pages and gives a fantastic safety feeling. If you read that, you have something you can rely on if you are doing the procedure. Everybody asks, of course, what are the side effects or the adverse effects? And let's go to this slide, for instance. You can see in the middle the major adverse events. So the major complications of Hifu are very clearly the second-degree skin burns. That's what we have only with these treatments. You have, of course, also minor adverse effects, but you have no severe bleedings and no need for transfusions like in the surgical group. This is a very interesting retrospective analysis of 27,000 patients who had fibroids or adenomyosis. And also here we see that skin burns are the major complication, also leg pain, but that is all. So all the other complications are minor ones, of course, bowel injury, acute renal failure, but they are very, very seldom. Skin burns are important. So Nuria is going to give you more details. I just show you one slide from Hifu for fibroids. And you see on the left side, you see an MRI pre-treatment. You see very clearly the fibroids. Then 14 days after the Hifu, you see the coagulated, the necrotic area. 4.5 months later, this is much smaller. And after 10 months, it's almost gone. And there is an average annual resorption rate of about 67%. On the left side here, you see a single fibroid before Hifu and after Hifu. And on the right side, multiple uterine fibroids. And I add here a picture of my good friend Raymond Zaidson from Soweto in South Africa. I think he has, it's in Nigeria, the same problem. They have fibroids, multiple big fibroids already in very young women. And you see, you have only the possibility to do surgery or you do Haifu. And the guys in Soweto manage to treat very big uteri with Haifu. Treatment of Haifu, of fibroids, you have traditional surgery. You see, very brutal in our hands now. Then you have the laparoscopic surgery. And then, of course, Haifu ablation. Important, as stated in the video already, no patient wants scars. After conventional surgery and after laparoscopic surgery, you have small scars. After Haifu ablation, no scars at all. And this is the view intra-abdominally, left laparotomy, in the middle laparoscopy. On the right side, you see nothing at all. The second most important indication is adenomyosis. Adenomyosis is a uterine disorder in which endometrial glands are pathologically demonstrated in the uterine myometrium. We call adenomyosis also endometriosis interna, and this in contrast to the endometriosis externa, where the endometriosis is in the ovary, in the abdominal cavity. If it is in the uterine wall, it's called adenomyosis. I have here one case of focal adenomyosis. We see on the left side the MRI before treatment. It's a T2 weighted image. In the middle, we see pre-treatment contrast enhanced MRI. And on the right side, the post-treatment contrast enhanced image. You see very clearly the necrotic zone. The same thing with the diffuse adenomyosis. On the left, pre-treatment, in the middle, pre-treatment with contrast, and on the right side, contrast after treatment. I finished my lecture with one of my first cases of diffuse adenomyosis that I had the pleasure to do with Dr. Dang in Chongqing about a year ago. So you have the MRI image, what is for me very clearly to understand. The ultrasound image that you have on your Haifu machine is much more difficult to interpret, and you need to learn that. Once again, everything is in one room, and you see, no, it's not an OR, no sterility. You are sitting there with your colleagues and the patients. Once again, very clearly. So you do the procedure. Very important after the procedure to have a look at the skin of the patient. Skin burns are always very unpleasant, but the patient will tell you that. She will say during the procedure, oh, it hurts. And then you can change your technique using a balloon. And you can also, if your beam is too close to the bowel, you can always use a balloon to push the bowel aside. So, as I said before, after 1 or 2 hours, the procedure is finished and the patient is, as you can see, very friendly to me. She is going to her room and she can leave the same day or latest the next morning. This is the image 24 hours, the MRI 24 hours after, let us say, my first adenomyosis patients. Very important pregnancy outcome after Haifu for fibroid and adenomyosis. The literature is not that rich, so that I will just give you a take-home message. Haifu seems not to increase the complication rate during pregnancy and delivery. Especially, very important, there is no increase in the incidence of uterine rupture. Infertility patients with adenomyosis seem to conceive spontaneously, so they do not need ART. And after Hifu treatment, they deliver healthy term babies. So from the literature and also from what my very experienced colleagues told me, Hifu is a safe treatment option also for infertility patients. Last slides, additional gynecological obstetrical indications for Hifu, cesarean scar pregnancy, and placenta creta. We have no time for that here, but I have also absolutely no experience with those two topics. Well, that's it, ladies and gentlemen. Thank you very much for your attention and thank you for coming. And I'm looking forward to answer the questions. I hope they will not be too difficult, but I have Nuria next to me. And I thank you once again, also on behalf of the ESGE working group. Thank you. Talk to you later.
Yes, thank you so much, Hugo. That was very nice and very stimulating. Yeah, I'm sure there's so many questions that will be asked later on. Yes, I want to recognize the presence of the SOGON president who joined us later on, and the first vice president as well, and the presence of our friends from Chongqing. Peng is on, as well as Samil, that's Banksili. They are both present at this webinar. Yes, without much ado, after the foundation has been laid, I think the next topic will be drug treatment for fibroids and adenomyosis. And Professor Aumakhu will be talking to us on that topic. Chris is spent all his time treating patients with fibroids and adenomyosis, so he would be talking for a lot from experience. Chris, you have the floor.
Thank you very much. I hope you can hear me. Am I audible?
Very.
Okay, thank you very much. I would like to, first of all, thank Dr. Bayomi Ajayi for organizing this, putting this together. And I also thank you for all the assistance you're giving to SOGON for a lot of things, especially when it comes to continuing medical education. My topic is pretty straightforward. And I know that there are a lot of people here who may not be medically inclined, so I will try and be as gentle as I can. We're talking about drug treatment for fibroids and adenomyosis. The Haifu presentation has kind of laid a foundation for this, so I'm sure we'll be able to flow as we go on. Dr. Ajayi has already introduced what we're here for, so I don't want to dwell on that. We're going to talk about non-surgical treatments of uterine fibroids, uterine disorders, and the two disorders we're going to talk on today are uterine fibroids and adenomyosis. Fibroids are something that we all seem to know. So a lot of us here would know. I mean, most people here are from Nigeria. Whether you're medically inclined or not, you will know what fibroids really are. Let me declare my personal interest here so that, like we always do with these presentations, this presentation is purely for academic and knowledge purposes, and I'm not doing it to benefit the marketing of any products. When this webinar was put together, I got some phone calls from drug companies and saying that SOGON wants to endorse some drugs, and I said no. This is just purely for academic purposes. I do not work for any drug companies. I'll try to make it, or company, I'll try and make it as simple as possible. Because like I said, I know a lot of people here are joining it just to listen to what the topic holds. And I'm only affiliated to the University of Ibadan, where I work, College of Medicine, where I also work, and University College Hospital, where I also am a consultant too. And I'm Secretary General of the Society of Gynaecology and Obstetrics. So let's get down to what we're here for. I'll break this presentation into two parts. There's no doubt that drug treatments for these uterine disorders are limited, because we know that the drugs are usually used for, the attempt usually with fibroids, like, let me get it out of the way. Fibroids are usually non-cancerous growths in the uterus. For those who don't know what uterus is also, the womb is also called the uterus, so that you don't get so confused. And then fibroids are usually sometimes described as being stones in the womb of a woman. So fibroids in the uterus, uterine fibroids they're not cancers. They're cancers in less than 1% of patients. And they are not so, we usually will not, we look at them as being benign. Benign means that they are non-cancerous tissues, but they are growths. Tumors are growths in an organ. And they are common in women of childbearing age. And when we say childbearing age, we talk about women between the ages of 25 and 45, where it's a period where women have their children. They are also known as leiomas. So you may see it in some books or now social media, or you may see it as being called myomas. Many people have fibroids with no symptoms. The general problem is sometimes in our patients, and fibroids is very common among our population. I'm talking about the Black population, the Negro population. And one of the problems that happens with fibroids is when women are asked to go and do medical tests or to go do an ultrasound, maybe for any employment or for something, and then they come with a scan saying they have fibroids, and they start running around trying to find out solutions to the problem. Most times they don't cause any symptom. They're just growing there quietly without making any, giving any woman any symptoms or complaints. But whenever they have these complaints, the common complaints are usually pain and then bleeding. Bleeding most times could be heavy menstruation. And you can see from the what we previous speaker said, and what I'm going to say soon, because they're in the womb and women menstruate from the womb, you can have excessive menstruation, which is a bother for many of our patients. So there are growths in or in the walls of the uterus. They are usually described as being smooth muscle cells with connective tissue. So when we look at them, either we look at them as when we see them, or we look at them under histology, which is under a microscope, they're usually simple muscular tissues with some connective tissues to them. A few people will have one, but in our population, we tend to have multiple fibroids. So you have them growing from the size of maybe the seed of an apple to something larger than a grapefruit. And indeed, I would have wanted to show some pictures of very, very large masses, but I felt that wasn't for this presentation. So we tend to have very, very big fibroids because many times patients do not, they have these symptoms and they don't present to the doctor. Even when they present to the doctors, they present with pain, maybe some little swelling, or even excessive menstruation in some cases. And doctors tend to just give medications. That's if they get to see a doctor. Or sometimes they do a lot of self-medication, and sometimes they get symptomatic relief, especially with pain. They also shrink over time. Okay, so they can shrink and some can grow over time. So you see some women taking snapshots of fibroids. I know of some women who do scans almost every month or every 6 weeks to see if those fibroids are reducing in size. And it's quite common with those patients who go for alternative medicine. In our own environment, we have a lot of women who go for herbal treatments, who go for some native concussion kind of treatments, and they want to justify what they have used because nobody wants to have surgery. The previous speaker spoke about Haifu, said it all. Nobody wants to have a scar. It's surgical scars are not cosmetically right, good. And even the dangers of surgeries are also there. So fibroids are common, like I said, and they're mostly common from the age of 30, and then they get to menopause. You may ask yourself why. They are estrogen-dependent tumors in the sense that estrogen is usually higher in women around the period from menarche, which is the age of menstruation, to menopause. And they usually, towards the end of reproductive life, which is when you get to menopause, the estrogen level in the body reduces. And that's why they tend to shrink as you get towards the age of 45. So they usually shrink around menopause. And if you look at our population generally, about 20 to 80% of females generally would have fibroids by the age of 50. That is scary, okay? And it's unclear exactly why they occur, but they seem to develop because of, like I said, the estrogen levels that are higher during reproductive life. And they are the most common gynecological disorder, classically requiring surgery in our own environment because of the symptoms. The symptoms can be very bad. And then because a lot of our women also want to get pregnant. So when they do a scan, they sometimes, when they have fibroids, without proper investigation, or sometimes with even proper investigation, clinicians who are experienced or may not be experienced would put the blame on fibroids, and a lot of women go in for surgeries because of that. So this is just a simple picture showing us the uterus or the womb to tell us really where the fibroids are really located. So if you look at this lower part being the vagina of the woman, and this upper part being the uterus itself, you can see there are some that grow just on the surface of the uterus, and those are the ones we call the subserous fibroids. We have some that grow in the muscle of the uterus, and those are the ones we call the intramural fibroids. And then we have some that grow in the inner line, which is in the endometrial lining of the uterus, and those are the ones we call the submucous fibroids. You can also have those in the cavity, and we can have some big ones that could just be on the surface of the, they may not be that big, on the surface of the uterus, which are called the pedunculated fibroids. Attempts have been made. So let me go now to my topic, which is the non-surgical methods or non-surgical drug treatment. So attempts have been made to finding cures for fibroids using drugs. And this has been on for so many years. Initially, both progestins, progesterone and estrogen are the hormones that women produce during reproductive life. And because these are the hormones that are responsible for fibroids, they also want to have, people have researched into hormones that could go into mostly anti-oestrogenic, because we know estrogen is what makes fibroids grow. So people have researched into trying to have drugs that could reduce the level of estrogen, or to make them, or specific drugs that can make fibroids not grow. So initially, both progestins and estrogen progestin combinations have been utilized, although proof of their usefulness initially was lacking. A major step was achieved when the peptide analog of the gonadotropin-releasing hormone was produced. And this was the first there was the super agonist properties, and then subsequently those that were active against them, which are the antagonists. Initially, the agonists they produce side effects because being anti-oestrogenic, they tend to produce some side effects which may not be so tolerable for a woman to tolerate. Eventually, this problem was actually overcome when there was the synthesis of a compound called Sertrolex. Most women with fibroids, like I said earlier on, remain asymptomatic, and some may develop symptoms gradually over time. The common symptoms, like I said, we could include heavy menstrual bleeding, which is called menorrhagia. They can have painful menstruation, which is called dysmenorrhea. Some may have pain that are not even, which are not dependent on the menstrual cycle. So they can have pain almost all through. There's no time they don't have pain, or they can't even associate it or pin it down to whether it comes at the beginning of the cycle or not. And then they could have urinary symptoms, fatigue, and constipation. Constipation is quite common with those very big fibroids. And like I mentioned earlier, they usually they could be associated with infertility in our environment. So when they are symptomatic, the numbers or how many there are could be a guide to how the symptoms are. Also, the location is critical, because if they are going towards the bladder in front, then they will tend to produce urinary symptoms. If they are going backwards towards the rectum, they tend to produce gastrointestinal symptoms. And of course, if they are being massive in the abdomen, they tend to give the woman a swelling in her abdomen. So medical therapy may have been employed usually, initially, and most times as a preoperative adjunct to control the excessive menstruation, which is called menorrhagia, or sometimes to reduce the size of the fibroids. They also been used temporarily as relief of the patients who are not stable, who are not poor, who are not willing to consent to surgical intervention. You see a patient, you counsel her, you tell her, oh, she has fibroids and she has terrible symptoms. You may want to give them these drugs to relieve them of their symptoms. And then, of course, if they don't want to have surgery, but the dangers of surgeries are there, not just mortality, but morbidity, meaning complications that can arise from the operations. Because really, in our own environment, most of our patients who have symptoms are usually advised to have surgery. So sometimes you want to relieve their symptoms and you actually suggest have to put them on drugs. Currently, the options of medical management of fibroids are not stable for long-term therapy due to concerns of safety, because usually the symptoms, the safety of the drugs are usually a problem, and the side effects can be terrible. And most of the drugs that tend to be available, when you use them for long periods and you stop, tend to have first of all, they're not effective after some time. And then sometimes they have this rebound effect, which is like the tumor really going back again to the way it was. Today it's widely accepted that in women with asymptomatic uterine fibroids, those that do not have symptoms, who do not desire pregnancy, no special treatment is required, but these patients may need to be seen or monitored periodically. What do I mean? So if you have a patient who's done a scan or who's seeing you, or a patient out there who has tiny fibroids, or even large, big fibroids and are not causing her any symptoms at all, then she's better off being watched. And then she can be followed up. So not essentially being that every fibroid you see, you want to go after it. For this reason, most conservative options that minimize the risk of fibroids or morbidities are usually selected. So evidence of medical treatment has been on for so many years. I was looking at a paper in 2016, which showed that there were so many studies, about 75 randomized controlled trials have been done on drug treatment, various drugs which were out there. And they concluded that the overall quality was very low and there was insufficient evidence to recommend any medical treatment in management of fibroids. But at the same time, in the same year, there was a systematic review, which also evaluated 52 studies and reached the conclusion that there was the efficacy of several agents and opening up promising avenues for development of medical alternatives to surgery. And these went in, and then a lot of drug companies cashed on it to try and see if they could improve with the drugs that were available there. These are the drugs that are really available now for medical management of medical treatment of fibroids. And I'll just mention them and I'll just dwell a little bit on them so that we know a little bit about them. There's no medical treatment that completely eliminates fibroids. Okay? Most of them will symptoms relief, some may actually shrink the tumors. The non-steroidal anti-inflammatory drugs like your ibuprofen are sometimes very good for pain. And then the gonadotropin releasing agonists, the progesterone pills, oral contraceptive pills are progesterone releasing joint devices are also being used basically to reduce the symptoms that women do feel. The drawbacks of these methods that are available with the oral contraceptive pills, which is the usual daily pills that women take for contraception, they can be used to treat menorrhagia and dysmenorrhea in these patients. So heavy menstrual flow and painful menstruation can be treated by using these drugs, but they cause breakthrough bleeding. So some women will bleed in between their periods, and then the drawback is that they are known to increase the size of the fibroids. The long-acting intrauterine contraceptive devices, they lead to more irregular bleeding, and then sometimes there's risk of expulsion. And the generic analogs are usually monthly drugs, injections, and they're given for about 3 to 6 months. The effects are transient, and these fibroids usually return to their pre-therapy size within months of when you stop the drugs. They actually suppress estradiol, they cause hypoestrogenism, and about a lot of patients experience hot flushes. These are like menopausal symptoms. And they also reduce the bone density in many patients. So let's quickly look at a few of the drugs and see how it goes. The oral combined oral contraceptive pills, which I said like the pills that women use. A lot of studies have supported the use of these pills because they reduce the menstrual bleeding in women with fibroids. Menorrhagia is the most, in patients who have symptoms, menorrhagia or heavy menstruation is the most common symptoms. Also, the uterine growth is stimulated by both estrogen and estrogens and progestins, which we know. And then, so the combined oral contraceptive pills were initially considered as a risk factor for fibroid growth. However, a recent meta-analysis suggests that uterine fibroid should not be considered a contraindication for the use. And in short time, combined oral contraceptive pills can actually be used to, studies have been shown to actually be used to reduce the heavy bleeding that is associated with fibroids. Some studies also suggest that they are not recommended for mammal-related symptoms, whereas some use them, but close monitoring of uterine size and their locations are very important. Like I said, sometimes they've been known to be associated with the tumors actually increasing in size, but they can reduce the blood loss that you see with menstrual flow. So the American College of Obstetrics and Gynecology in 2008 published a study where they said there was a lack of robust evidence regarding the efficacy of these medications, but they said they encouraged trials, and not much has really changed with the way the feeling of these drugs are. Progestins, these are another set of drugs that can be used. These are cyclic, they can be given also cyclically for bleeding, to control bleeding. And they've been used for cases where you have non-organic abnormal uterine bleeding. So such as perimenopausal bleeding, and when you have endometrial thickening or hyperplastic tissues that are related to the bleeding. And this can actually help in reducing the blood flows, the heavy flows. Although they are usually administered in treatment of fibroids, as with the combined oral contraceptive pills which I mentioned. There's some opinion that they should not be recommended. They should not be recommended to treat symptoms, other symptoms associated with fibroids. And there's a lack of high quality evidence assessing the efficacy of these medications, which I also said, because they also can even promote the growth of the tumors. So treating of uterine fibroids with progestogens may be effective in some cases, but such treatment has been associated with even histological changes of the fibroids. And some studies have suggested that histology can actually be mistaken for cancerous growth when they eventually have surgery, or they have to take out the tumors, and in which histology has to be looked at. So they tend to sometimes, women who have had progestins tend to histologically have cells that look like gliomas, sarcomas, or smooth muscle tumors of unknown malignant potential. So sometimes they can be mistaken for that. And this is because they increase the cellularity and mitotic activity of the cells when they're taken, especially when they're taken for very long periods. The levonorgestrel releasing intrauterine systems came into being a couple of years ago. And these are intrauterine devices that are inserted just like your IUCDs they have, but they have levonorgestrel. And so many studies have shown the improvement in menstrual bleeding and the blood levels, the plaque cell volume and hemoglobin levels when used with women with fibroids. They don't change the size of the fibroids, and even when looked at as MRIs. But once inserted, they can be effective as both a contraceptive device and as for controlling hemorrhage in the women for as much as 5 years. And because it's not administered regularly or systemic as a drug and injection, it's just there as a device. They have minimal side effects have been reported in patients. However, there's increased risk of expulsion, especially when you have tumors that are big or they started very close to tumors in the endometrial lining of the uterus. The GNR agonists have been extensively studied. They are very popular now for treatment of symptoms with fibroids. Cochrane studies of 26 randomized controlled trials have been shown to show the efficacy of these drugs when they're used before hysterectomy or myomectomy to relieve these symptoms. Yes, hysterectomy is really the surgical removal of the whole uterus or the womb itself, for those that don't know it. And myomectomy is when you surgically remove the fibroids. And it has been shown that with this, there's been an increased significant level of the pre and post operative hemoglobin levels, and then in these patients. And there's been some reduction in volume, uterine size, and the duration of stay in hospital have also been noted. But the blood loss at incisions are also reduced with this use of these drugs if you now opt for surgery. But I must say that there's no benefit when you have very large fibroids if you want to try that to myomectomy. Okay, especially with, but there's absolutely some benefit if you want to go and do laparoscopic myomectomies for those patients. And they also reduce the operative time. They also help in controlling the hemorrhage. And of course, the risk of blood transfusion is reduced. Okay, I won't dwell much into most of the things about them. I think I can skip that. The gonadotropin releasing antagonists have also been used. They act immediately to suppress the secretion of the follicle-stimulating hormone and luteinizing hormone by blocking the pituitary gonadotropin releasing receptors. And this has subsequently led to the reduction of the estrogen levels and then improvements in bleeding in patients. And this also have been shown to reduce the uterine size, especially during the initial treatment. But after that, there is usually a rapid growth of it. Other things that have been tried and also use the selective progesterone receptor modulators. We have your mifepristone, talapristone, etc. These have also been used, usually also for fibroids. Mifepristone and isopristone have actually been shown to be effective in reducing the size of the fibroids and improving the related symptoms that we see in this patient. The aromatase inhibitors have also been used. They actually block the peripheral ovarian conversion of androgens to estrogens. And several studies have also shown the effectiveness of these drugs by they actually reduce this, actually shrink the tumors a little, and then they can also improve the symptoms of patients. The non-steroidal anti-inflammatory drugs like your ibuprofen, they don't really act on the fibroid tumors itself, but they are good at reducing pain in patients, especially those that have big tumors or tumors that are encroaching on surrounding structures that give the patients pain, but they don't reduce bleeding in patients. So I quickly go to adenomyosis. Adenomyosis has been sometimes mistaken for fibroids. They grow also in the intramuscular, in the wall of the uterus, and the symptoms usually sometimes present like those of uterine fibroids. The condition which is in the inner lining of the uterus and in the endometrium, breaking through the muscular layer of the uterus, which is the myometrium. They can cause similar symptoms like you have with fibroids. So they can cause menstrual cramps, low abdominal pressure, bloating before menstruation, and then they can also have heavy menstruation. They're usually located in bigger surface areas than in fibroid you would see. So you may just see the condition located either throughout all through the uterus and the bigger layers, or you can even have them in just a tiny area of the uterus. And it's been said to be the misdiagnosis in women's health, because some people, especially many years ago, when we didn't have very good diagnostic methods of diagnosing diagnosis of fibroids, people actually went in to do mammectomies and they got there and they found out adenomyosis. So they are just proliferation or hypertrophic of the endometrial glands and the stroma of the mammectrum in those women. Some people say the gold standard of treatment is usually with hysterectomy. That's thought before, but we now know that we can use other things like the Hifu, which was suggested earlier on. So this is looking at the normal uterus, just a diagram of it, and you can see what the adenomyosis looks like. So the diagnosis of adenomyosis is usually difficult. This subsequently results in difficulty in the management of these patients, especially those who have symptoms. But they also will have a strong desire to preserve the uterus. So they want to keep their uteruses. Conservative treatment is still needed in the group of patients that require fertility treatment, who want to get pregnant, and those who want improvements in the quality of life, because the symptoms can be very terrible for the patient too. This is just looking at the management options for them, pain and menorrhagia. Drugs can be given for that. We also think about fertility preservation in them. Symptomatic medical treatment is available. Conservative surgery can also be done to remove just part of the uterus where you have the tumor. And then radical surgery has been attempted, and other things, including use of drugs, which I mentioned just a few, and then the Hifu, which we just listened to. So medical treatment of adenomyosis always follows the principle of, like we have with endometriosis. Endometriosis is presence of abnormal endometrial tissue in any part of the body other than the inner lining of the endometrium. So it's usually aimed at reducing the production of endogenous estrogen, or reducing the growth of the differentiations with progestins. Clinical evidence points to clear deleterious effects of uninterrupted ovulatory cycles, of development and persistence of adenomyosis. So symptoms of adenomyosis usually appear after menarche and vanish after menopause, just like we have with your fibroids, and that's why there's always that confusion with them. The objective of medical management of adenomyosis with the drugs that are available, we talk about inhibition of ovulation by reducing or making sure they also take care of, make sure that menstruation is reduced, and then they achieve a stable steroid environment, which is based on the concept of response of the endometrial tissue. Medical therapies commonly used to treatment of adenomyosis are similar to those with endometriosis, because they are based on the fact of their acting on the hypothalamic pituitary gonadal axis. Medical therapies, some of them are similar to what we saw earlier on. So we have the gonadotropin releasing agonist, we have the oral contraceptive pills that we mentioned earlier, progestins, danazol, which are androgens, are also available, and the selective estrogen receptor modulators, selective progesterone receptor modulators, and the aromatase inhibitors have also been used. These agents actually create a reduced estrogenic environment, so that there's suppression of the endometrial cells and they don't grow. So that's the aim of medical treatment. However, medical treatments are symptomatic, and they can reduce the tumors, but the lesions can survive when you stop using the drugs, or even after prolonged use of the drugs. So they tend not to create much difference in the size. So these are some of the drugs, just showing some of the methods that are available. I'll just mention a few of them. So the progestins and the antiprogestins, like you have with the gastrinone, they appear to be more effective at reducing all symptoms up to like 12 months. They can go up to like 12 months. But the non-testosterone acetate is actually with a marked degree of pain relief and satisfaction with treatment after 1 year, although the efficacy seems to be more gradual, but progressively better with a longer duration of use. The drawback of this is the reduction of libido, which some women do experience. There are contraceptive pills, which I mentioned earlier, and they are very good, especially with the it enables satisfactory long-term treatment and control women who have symptomatic endometriosis or have symptomatic adenomyosis. So they're quite good with that. The danazole, has a complex mechanism of action, inhibits sterogenesis by lowering the mid-circle LH and such, and then also increase the serum free testosterone levels. They result in a masculine kind of androgenic environment. So this can also, they're good at reducing the pain that patients do have, but the problem with them is the side effects that they have. And they can relieve pain in most of the patients who are treated for up to 6 months. We should also be aware of the side effects, especially the androgenic side effects which we have with them, which are also a problem with these patients. The levonorgestrine releasing intrauterine devices or system has been shown to reduce the dysmenorrhea that is also present with them. They also reduce the abnormal uterine bleeding that patients with adenomyosis can also have. And they are also effective, more effective compared to other drugs that have been used. The gonadotropin releasing hormone agonists are also very effective against the pain that adenomyosis gives. They should also, however, be careful about the associated intolerable hypoestrogenic effects which they have, which can lead to genital atrophy, mood instability, negative impact on the bone health, and then possible cardiovascular effects that they will have. So people usually talk about, and then the problem with them is the cost. They are very expensive drugs that are available for our patients. So in conclusion, the medical margin of uterine fibroids may provide symptomatic relief of uterine fibroid-related symptoms, along with opportunities to maintain fertility, because our patients still want to, whether you have, our patients with fibroids most times want to still have children. And a wide range is now available, and some require further evaluation. So a lot of studies are going on. Currently, the gonadotropin releasing hormone agonists and the selective estrogen receptor mediators are very good and are most effective medical therapies. The choice of treatment depends on the patient's personal treatment goals, as well as the efficacy and need for interventions. As far as adenomyosis is concerned, the goal is important, and we talk about symptomatic relief of symptoms and then possible increased fertility in this patient. Therapeutic goal of medical treatment is not lesion reduction, but lesions can survive drug therapy for long periods too. Therefore, treatment should be tailored to the specific symptoms or special requests of the individual patients. As severity of pain may vary in women with adenomyosis, and more importantly, the same type of symptoms may be different in patients for different women. Thank you for listening to me. These are my references. Thank you very much.
Yes, thank you so much, Professor Aumakhu. Yep, that was very illuminating. I think we just go straight on. We're going to take questions. You have a lot of questions already, but I think we better just take questions at the end of the presentation. So I will ask Dr. Ahmed Ninalowo to please start with this talk. He's talking about uterine artery embolization in uterine fibroids. Thank you so much, Ahmed.
Can everyone hear me?
Yes, we can see you. We can hear you.
Okay, very good. Sorry about that. I was going next. All right, my name is Dr. Ahmed Ninalowo. I'm a vascular and interventional radiologist here in Lagos, Nigeria. I provide basically the entire spectrum of vascular and interventional radiology, and also have a special interest in women's health and work with a lot of gynecologists, both locally and internationally, to provide gynecological treatments, including uterine fibroid embolization. So I think the last speaker already talked about what fibroids are, but basically they're benign tumors of the reproductive system, typically benign tumors of the uterus, and it's the most common tumor in the female genitourinary tract. And I typically think about fibroids and the symptoms fibroids cause in two different categories. I think about symptoms that are of menstrual abnormalities and then symptoms that are of pressure symptoms. So typically of menstrual abnormalities, we're typically talking about bleeding generally and menstrual cramps and basically frequency of bleeding. And then the pressure symptoms women typically present with are usually pain, frequent urination due to the size of the fibroids typically sitting on the bladder, symptoms like constipation or back pain. So I don't think anyone still knows exactly what causes fibroids, but we do know that hormonal imbalances are a significant contributor to fibroids. And as we know, especially here on our continent, a lot of women have fibroids. 60 to 80% of women have uterine fibroids by the age of 50. But many women are unaware of them. And as the last speakers talked about, they typically get aware of them when they get a physical exam or they get some kind of imaging when they discover fibroids are present. And Black women are more likely to develop fibroids and are more likely to have symptomatic fibroids, and a family history of fibroids is also a significant risk factor in having fibroids. So fibroids could be in different locations in the body. So basically for the non-medical folks, this is the vagina here, and this is the cervix, and this is the womb, this is the uterus. And fibroids could be in any of the locations in the uterus. It could be within the cavity of the uterus. It could be close to the lining of the uterus. It could be outside near the serosal lining of the uterus, or it could just be hanging off of the uterus. And the location of the fibroid typically dictates exactly what symptoms you're going to get from the fibroids. For example, with the ones that are intracavitary or submucosal typically cause the most bleeding in women. And a lot of patients also ask me, if you've discovered that you have fibroids, do you actually require treatment? And the big answer to that is no, because there are a lot of women with fibroids and you do not require treatment until you actually have symptoms. So only a small percentage of the women who actually have fibroids require treatment. I've also been asked if fibroids typically disappear on their own. The answer is no for a lot of women, especially, but those do disappear on their own or start to involute when you get to menopause later on. So basically the only time you should get fibroids treated are if you're having problems with them or if they're impacting on fertility. So talking about treatment options for fibroids, the local treatment options that were available in Nigeria are typically surgery, either medical therapy or surgery, meaning hormonal therapy, as the last speaker talked about, myomectomy, which could be laparoscopic or hysteroscopic. Also, a hysterectomy is also an option. What we added to the local treatment options is uterine fibroid embolization. And I'm sure that Nordic Fertility is also, I think, is already performing Haifu, or they're in the process of getting Haifu started in the country, which is quite exciting because having more and more minimally invasive treatment options for women is the way we're going in medicine generally. So what is uterine fibroid embolization? It's a minimally invasive treatment option where we could target all of the fibroids within the body at the same time. Size is sometimes an issue for us. If you have, especially here in Africa, where you have women with really big fibroids, I typically try to shy away from those women and try to push them towards gynecology. We have met quite a few women, though, that have actually come from the gynecologist and do not want surgery under any circumstances. And we set their expectations correctly for symptoms such as bleeding, which I will talk about. We could certainly get that way better with fibroid embolization. But when you talk about the bulk of the fibroids, we could only do a little bit in getting that size of the fibroid smaller compared to conventional surgery. Compared to conventional surgery, we have a minimal complication rate. It's been proven to be effective over 30 years. This has been practiced in the West for a very long time. Obviously, has not been present in Nigeria, but it's readily available in the country now. And obviously, our patients could get through a quick recovery. So for our preoperative evaluation, we usually do a consultation, take a gynecological history, do a physical exam, run laboratory tests, and then the typical pattern before was to get MRI on every woman that needed fibroid embolization or came to us with fibroids. We've kind of shied away from that now. And most of the centers in America, especially the outpatient-based labs, have always shied away from getting MRI on everybody because it could get quite expensive. most of the information we need to do a fibroid embolization, we could obtain from doing an ultrasound. There is a subset of women, the older women, especially women who come to us and say, you know, I wasn't really bleeding before, but you know, I'm now 45 or 46 or close to 50. I just started bleeding all of a sudden. Those women, we kind of take a step back and make sure that we do an MRI, or sometimes also send those women to a gynecologist to get an endometrial biopsy to make sure there's nothing going on other than fibroids before proceeding with uterine fibroid embolization. So those subset of women, we almost always get an MRI on. So how do we do fibroid embolization? Typically, we get access into the artery, either the femoral artery or the radial artery. A catheter is inserted into that artery. And essentially, the next thing we do is we go find the uterine artery. And once we find the uterine artery, and all of this is being done under monitoring on x-rays. And once we find the uterine artery, we get a microcatheter very close to the distal uterine artery in the transverse segment, and then we deposit our particles. And we know that fibroid embolization the procedure itself is not painful, right? We typically give women some conscious sedation for the procedure just to keep them comfortable. However, after the procedure, we do know that you could develop quite a bit of pain and cramping, and this varies from woman to woman. So we typically now start a medication regimen the day before the procedure that basically gets the body ready for the pain it might be getting. And then we have everybody come in and PO overnight. Then we do the procedure with typically fentanyl and Versed, and also give the women ketorolac, which is an anti-inflammatory drug, which is quite a strong anti-inflammatory drug and significantly reduces the risk of pain. Sometimes we've also added something called an hypogastric nerve block to the uterine fibroid embolization procedure, and this has been shown to significantly decrease pain in a lot of women. And this typically is an addition to the procedure where we use a 21 gauge needle and go directly through the skin of the woman into the hypogastric nerve region to deposit bupivacaine and steroids. So on the procedure day, we typically start an IV, which is started by the nurse. You're giving some pre-procedure medications before you come into the room. And then once you come into the room, this is the most favored way to do uterine fibroid embolization now, which is the radial artery. The radial artery is one of the arteries in the hand here, and the ulnar artery is on the other side. The radial artery is readily palpable, and we could get in there very easily using ultrasound guidance to get into the radial artery. And from this artery, we basically put a very long catheter in and go all the way up the arm and down the chest and back down into the uterine artery. And when we're done with the procedure, we basically put this band on. It's called a radial band. It holds pressure at the site of the radial access, and the woman could basically just walk off the table. That's different from using the femoral access. The femoral access is in the groin. If we use the femoral access, we could get to the same artery, but when we're done with the procedure, the patient has to lay flat for 6 hours. So over 99% of our fibroid embolizations are now done through radial access. If for some reason we are not successful through radial access, then we'll change over to femoral access, but women tolerate this much better with the radial access. So this is just a technical picture showing, we typically don't get this picture on all women, but this is academic. This is a pigtail catheter that's been placed into the aorta, and these are the kidneys on both sides here. These are the renal arteries, and this is the abdominal aorta. This is the common iliac artery, and from the common iliac artery, you could branch into the internal iliac artery and the external iliac artery. What you see here is this very prominent artery, that squiggly artery that goes very medial. And on the other side, you see this artery here. And that's the uterine artery. And the uterine artery is typically very big in these women and very prominent because fibroids love blood flow, and which is the concept of uterine fibroid embolization. We understand that fibroids love blood flow, and they're typically kept alive by blood flow and hormones. So we use a catheter to go select the uterine artery. Now this catheter selected the uterine artery, and when we inject that catheter, what we see here on the right side, this is the right uterine artery being injected, is there's a fibroid here, which shows significant vascularity, and the entire fibroid is being shown on this picture. However, only half of this fibroid is being shown because this fibroid is being fed by both the right and the left uterine artery. So what we do is we treat from the right uterine artery, we get a microcatheter down this artery to deposit our particles, and then we go into the other artery on the left side. again, from the same access to treat the left uterine artery when we're done with the procedure. This is just a video depiction of what it looks like angiographically when we inject the uterine artery. You could see that that artery fills up, and in this case, you see very vascular fibroid mass sitting there in the uterus. And in this case, again, we treat the right side. We get into the transverse segment with a microcatheter before we deposit in our particles. And then we go into the other side. There are two classes of particles we typically use now. We either use polyvinyl alcohol, which is PVA, or we use embospheres. And now we use a combination of both because it's been shown that with embospheres, the pain is typically less than PVA. So what we do is we start with embospheres for the procedure, and then we end with PVAs because embospheres is a lot more expensive. So this is a depiction of the microcatheter depositing particles, and these particles basically come out into the fibroids. And what we want to do at the end of the procedure is to completely fill the capillary network of the fibroid so that no blood gets to the fibroid. And the way I describe it to patients is basically the analogy of a bridge. If you have a bridge and you put a bunch of trucks on the bridge, then the cars can pass by, the cars being the red blood cells in this case, and the bridge being the bus being the particles. So essentially, you're just shutting off flow from that artery. And after the procedure, we typically admit patients overnight for pain control for one night. In America, actually, in the OBLs, we send our patients home typically the same day. And the reason for that is we know that if a patient has pain that is not controlled by the medicines that they've taken home, it's easy to access an emergency room. It's not the same in Nigeria where, you know, hospitals are not typically accessible, especially in the late hours. So we keep everyone in the hospital for the first night. And all our patients typically go home about 8 or 9 a.m. the next day, no matter what time we finish the procedure. And we typically follow up at 2 weeks and at 3 months after the procedure. So what are the results of uterine fibroid embolization? We've shown that the success rate for improving symptoms such as bleeding and pain from uterine fibroids is 85 to 95%. And I've been able to reproduce that even here in Nigeria in that number of patients. However, we could only reduce the bulk of the fibroids by about 50 to 70%. What I've seen actually of my local experience is it's more like 50 to 60% instead of 50 to 70% in reduction in size of the fibroids. But again, even that reduction in size, even if it's 50%, gives them symptom control and gives a lot of patients the satisfaction they are looking for from a fibroid procedure. This is actually one of my first patients in Nigeria. This is a T2 weighted MRI for the folks that are not medical to orient you. This is the back of the patient. This is the front of the patient. This is the bladder here. And this is the uterus. And in the uterus, you see all these black masses here are all fibroids. And this is actually a cervical fibroid that's in this lady. And for a patient like this, we have to have a serious discussion as to if the cervical fibroid was embolized, what happens if it doesn't come out itself? That means you would have to get an evacuation of that fibroid if you get basically slow degeneration causing a lot of shedding. For her, interestingly, if she had a dramatic result, this is about 5 months after the procedure, the big fibroid and the fundus melted away and all of the small fibroids melted away, and the cervical fibroid she actually expelled and sent me a picture of it. So she was quite excited. This is another patient, and I like to say, another patient. I like to show this picture to a lot of my patients. This is a coronal T2 weighted image. And in this case, this is a fibroid here, and this is a fibroid, and this is a fibroid. And this is the same patient 5 months later. You could see that this fibroid and these fibroids are completely disappeared. However, this big fibroid here is only decreased in size to this. So it's important to get the concept of uterine fibroid embolization and set the expectations of patients correctly. Especially in Nigeria, we have to do that very, very accurately because some of my patients come in and say, oh, doc, my symptoms are completely gone. I feel great. But I'd like to get an ultrasound or an MRI to see what the fibroid looks like now. And you do an ultrasound and you say, oh, man, it's only reduced by 50%. But the expectation is that the fibroid should be completely gone. But you tell them, you remember we talked about it, you know, your fibroid might not completely disappear. It would shrink to a size where it's not causing you symptoms anymore. But it might not completely disappear based on your anatomy and physiology. So what are the possible complications regarding that are associated with fibroid embolization? So post-embolization syndrome is typically experienced by most women, where you have pain and cramping after the procedure. You may have a little bit of nausea. I've actually not experienced a lot of patients with vomiting. Some patients may have generalized malaise, which is self-limiting because you know your body has gone through something in the week after fibroid embolization. Other possible complications include bleeding at the access sites. That's very rare. Especially in interventional radiology, we use ultrasound to get access into all of the vessels we go into. So our bleeding complication rates from access sites is quite rare. Also, the risk of an endometrial infection is quite rare. We only give 1 dose of an antibiotic for the entire procedure, and we typically do not do any post-op antibiotics. One thing I do talk to a lot of patients about is the possibility of fibroid shedding or vaginal discharge post-fibroid embolization, because when some of those fibroids die, they do come out either with menstruation or they do come out as flakes without menstruation. In 2 years now in Nigeria, I've experienced expulsion in 2 women. One of the women was a woman who had a dominant fibroid, submucosal fibroid, which basically got expelled, and she couldn't expel it herself, so I had to send her to a gynecologist to help me get it out transvaginally. Another woman was undergoing expulsion and decided she was just going to wait it out until it completely expelled, and she did not go to gynecology to get it out. Personally, I've not had a woman we had to send to a hysterectomy post-fibroid embolization for any complications. But if you look at the data, the risk of having to do a hysterectomy for a complication is less than 0.5%. So I'd like to touch just a little bit on the last topic of fibroids, fibroid embolization and fertility, which is something a lot of people talk about and a lot of questions are asked about. And the first answer I would give is no one still knows all of the answers when it comes to fibroids and fertility. Excuse me. No one still knows all the answers, but we do have a bit of literature in radiology. In 2010, this is a paper by Mohan et al. That was a systemic review of all the literature to date analyzing pregnancy and complications of pregnancy in UAE. And in this study, 34 studies were analyzed and 21 studies were in the final analysis. And what they found was that the cumulative pregnancy rates from the pooled analysis was about 58%, which is comparable to the adjusted rates in the general population. The miscarriage rate was also about 28%, also comparable to the numbers quoted in patients with untreated fibroids. And the cumulative rate of preterm delivery was also similar to the general population. This was another paper in 2017 where they collected data for 10 years in 359 women who were trying to conceive but were unable to conceive and had either fibroids or adenomyosis. And the median follow-up in this paper was 69 months. After 69 months, 149 women became pregnant. 16 of them had several pregnancies, and 150 live newborns were from this paper, were from these women. It was also the first pregnancy in about 85.5% of women. And when they did the analysis, spontaneous pregnancy rates at 1 and 2 years were 29.5% and 40.1% respectively. And the probability of a successful pregnancy with live birth at 1 and 2 years was about 25% and 37% respectively. So this is the most recent paper looking at pregnancy. Well, basically not looking at pregnancy, but pregnancy was a secondary outcome in this paper. And this just came out in the New England Journal of Medicine in 2020. And this is a paper where they randomized patients to either myomectomy or uterine fibroid embolization, and 127 patients were randomized. At 2 years, they were substantially improved baseline scores in both groups, with scores of with uterine fibroid embolization being 80 plus or minus 22 mean, and a little bit better in the myomectomy group, having better quality of life outcomes. The menstrual bleeding scores were similar in both groups. There were no difference in the two groups in the level of biomarkers of the ovarian reserve. This is a question I have to answer quite a bit from gynecologists, talking about the decrease in ovarian reserve in patients who have undergone uterine fibroid embolization. Again, it's been shown that there is no difference in the two groups. And then there's still no conclusion on pregnancy. But interestingly, in this paper, out of 127 women, 9 women in the UFI group, in the uterine fibroid embolization group, got pregnant with 6 live births, versus 5 women in the myomectomy group got pregnant with 4 live births. But again, we still do not have all the answers when it comes to uterine fibroid embolization or myomectomy and pregnancy. So again, what do we tell patients? Well, every patient is examined and counseled appropriately and based on their situation. And it's very important to work collaboratively with gynecology, with fertility specialists, to examine women who are looking for future pregnancy. And I try as much as possible to work collaboratively with my colleagues on those patients. This is an example of one of those patients that was in my clinic where we saw a submucosal fibroid that was pushing into the endometrial canal. Again, this woman, we did not do uterine fibroid embolization on, and this woman may have been a woman who may have benefited from Haifu, but we sent her instead to gynecology for a hysteroscopic myomectomy, which was successful. That is my talk, and thank you very much.
Yes, thank you so much, Dr. Ninalowo. Yeah, that was quite great. And just like you said, I think we're trying to give our women the choice of not that everything is surgery, you have to open up, you have to open up. They need to have some minimally invasive and some non-invasive methods in the treatment of fibroids. And thank you for mentioning about fertility, which is a great question to women, especially in this part of the world. And I think is one of the things that we'll probably have some time to discuss towards the end of this webinar. So it's time for Nuria to give a talk, and she's going to be talking about Haifu and fertility. Welcome from Barcelona. Nuria, it's your turn.
Hello. Hello to everyone. Good afternoon. Many thanks to the organizing committee for inviting us to this webinar. I am Dr. Nuria Pons. I am a gynecologist, a specialist in surgery and minimally invasive and non-invasive techniques for uterine fibroids. In our unit, in Haifu unit in Terrassa, has more than 12 years of experience in treatment of benign uterine disorders with Haifu technology. And since 2017, I am part of this uterine myoma unit that includes Haifu unit inside in Barcelona, in Spain. Many thanks to the organizing committee, and also a few words to Haifu company, because they always help us when we need anything. I'm going to start with my presentation. Like any other myoma units, our myoma unit in Barcelona, we carry out all the available treatments, from medical to surgical options, from classic excisional procedures to occlusive procedures, and of course ablative procedures. Among them, I want to highlight Haifu technique. Today we're going to speak about this one, and that is one of the different options that we have to treat leiomyomas in our center. As Dr. Verhoeven explained before, and some of you already know, today we're going to talk about ultrasound guide Haifu. It's a technology developed in Chongqing in China by Professor Wang in 1997. As you can see, it's not a new technology, but Haifu is an emerging technology and non-invasive technique for the conservative treatment of solid, benign, and malignant tumors. In 1999, ultrasound guide Haifu was applied to clinical treatment of malignant bone tumor for the first time. In 2002, Professor Wang reported that ultrasound guide Haifu was safe and effective for treating uterine fibroids. In 2004, Haifu was approved by Food Drug Administration from USA to treat uterine fibroids. In 2009, was approved to treat women who want to become pregnant. And as Dr. Verhoeven explained before, in 2019, UK NICE published a very important medical guidance on ultrasound Haifu with evidence-based recommendations. Right now, more than 100,000 women with uterine fibroids have been treated through the world with a great success. I want to explain these slides because I think that it's important to put the situation over the wall. Explains where the technique is gradually spreading all over the world. In the Focused Ultrasound Foundation, we can see that more than 900 Haifu centers worldwide between ultrasound guide and MRI guide. And focused ultrasound is approved in the rest of countries, the world that you can see here: Canada, China, Europe, India, Japan, Korea, Middle East, Africa, Oceania, Russia, South America, and Taiwan. Here you can see in a map these orange spots, which marks ultrasound guide Haifu centers worldwide. Nowadays, in 2020, more than 80,000 women treated with Chongqing Haifu Company is a great number of treatments. Medical device dictamen in Europe was a reality in 2010. You know that Europe has more than 50 countries, everyone with own legislation. Even the European Union, that we are 27 member states, the healthcare governance is national level, and in some places, in some countries, on a regional level also. It's difficult to unify the systems, and even more difficult is in Spain, that we have 17 autonomous regions, and there are no focused ultrasound specific payments, but some negotiations and agreements with every hospital are in place. In 2019, the NICE guide give a step up in this situation, and we create the group, working group on non-surgical ablative therapy, because the ESGE support is essential in this situation. We need more randomized clinical trials. There are 3 ongoing in these 3 countries, but we need more, and these big organizations could help us to improve the numbers. Okay, here you have our ultrasound guide Haifu device, Haifu Chongqing technology GC200. Here you can see the therapeutic device, which is composed of a bed, a water tank here. Inside we found 2 transducers, diagnostic, the white one, and therapeutic, the orange one. We can move head, foot, right, left, and sagittal and transverse views. The other part of the device is composed with guide and control console. Here you can see Dr. Rodriguez performing a treatment. Here you see the ultrasound, real-time ultrasound guide. Here the MRI image. Here the control treatment, a screen treatment, and here this screen that Dr. Verhoeven commented to you. This is the place where we connect with the other sites, with the other Haifu centers, especially with Chongqing, and they help us when we need help, and always when we have difficult cases. Here a detail of the screen, therapeutic screen. This is the small one. Here you can see bigger one. Here the sagittal view, the skin, and the fibroid we are treating in this position. As you know before, therapeutic principles of Haifu, we explained you before, and only you have to focus that we need a slices, and to arrive into the focal point to achieve very high temperature to destroy the tissue. Focal spot is guided by real-time US imaging, and you can see in this picture the precision of technique is completely adequate, because you can see how surrounding tissue is preserved. The safety of the treatment is based on the great precision that treat tumors. This is supported by several studies of pathological anatomy that demonstrate a coagulative necrosis with clear and sharp boundary between treated region and not treated region. During the procedure, the patient lies prone on the mobile Haifu table with abdominal skin, with abdominal skin in contact with decreased water. Haifu treatment is performed and then intravenous conscious sedation to reduce discomfort and these patients' movements that could be very dangerous. As you can see in the video, we do an ultrasound scan pre-scan from the sagittal view, doing different sections with 5 millimeter separation between each one. We start to treat the deepest area and the central section, applying 1-3 seconds energy, resting 2-4 seconds between each one to reduce the temperature. The output power selected is around 300-400 watts, and we adjust according to the patient's discomfort, because she's under conscious sedation and she can speak with us, and she can say that she feels something in her skin, and we can reduce the power and we can reduce the energy exposure. The procedure requires between 1-3 hours, depending on the number, the location, and the size of the fibroids. The decision to stop to finish the treatment is made according to the intraoperative grayscale changes, as you can see here, and sonographic changes when we use contrast enhanced ultrasound that sometimes we use to check the treatment. Now, if the slides here, excuse me, and this is the result. On your left, you can see before sonication, sonographic image, sonographic with contrast, and MRI image. This is pre-treatment and this is post-treatment. Here you can see the ultrasound and contrast, and here you can see the image after treatment. Here the hyperechogenic grayscale changes, and here the effect of ultrasound contrast, and MRI confirms the expectations. After the treatment, women can observe, we observe them for 3 hours before being discharged, and then we start the follow-up. Excuse me, I forgot this publication, that we use microbubble not only to improve the treatment, even for enhance the effect of high intensity focus, and we can publish this article about this topic. As I said before, we start follow up the patient. Here you can see a pre-Haifu MRI, and here pre-Haifu with contrast MRI, and 3 months later post-Haifu MRI, and 6 months later this is the result. We follow the quality, the effective symptoms and health-related quality of life using the questionnaire validated that all of you know that exists. Okay, our results. Until the end of 2020, we performed 856 treatments in 722 patients, which means that 80% of patients were treated in 2 or 3 sessions, in 2 or 3 times. Only in 38 patients, the treatment was not achieved due to pain, to intestinal gas, to air in the bladder, because of obesity, or for poor visualizations. This could be one of the limitations of the treatment. After we will speak about these limitations, but some of you asking in the chat about this, and maybe this could respond some questions. Among the treatments completed, 68% were successful, and 32 need a surgical procedure. Sometimes it could be a myomectomy, and other times a SAT hysterectomy. This is a reintervention rate, 32%, with a 6-year follow-up. And although it may seem high, but if we compare with the current literature, it's similar that the other conservative treatments in the literature that we check. You can see the reintervention rate of when you do a myomectomy. This is in blue line. When you do a myomectomy, if you need a new surgery, sometimes you need an hysterectomy. For this is not easy than if you have a Haifu treatment fail, you could do a myomectomy at the first scale, and then you think in hysterectomy if you need, but not the first and the only solution. In some studies like this one, more than 600 patients who underwent myomectomy, 22%, needed another surgical procedure, sometimes hysterectomy. And in some studies, like the other one that you can see here, the effectiveness of Haifu was similar to laparoscopic myomectomy, but with a complication rate 50 times lower in Haifu branch, better recovery, and faster return to usual activities than the surgical group. Our follow-up, as you can see, there is a great reduction of symptoms and in parallel an improvement the quality of life. Our mean score change is greater than 20 points, which has been identified as a discriminator of clinical healing. And in the volume, in this table, you can see the volume decrease. After 2 years, the mean volume screen rate at the fibroids was 60%, achieving 77% at 8 years. Okay. Regarding the adverse events, the complication rate was only 10%, mainly first or second degree skin burns that did not have sequels, but we have one skin burn of 3 grade that she needs surgery to recover the integrity of the skin. The other ones are minor adverse events, and we don't have any bowel bladder injury and no amenorrhea cases. Haifu device limitations, we have to speak about no obese patients, because if BMI is more than 30, you will have problems to achieve the fibroid. Maybe you cannot see fibroids in the US, because if the fibroid is small than it's 1.5 centimeters, it could be difficult, but sometimes it's because of the subcutaneous tissue. It's difficult when fibroids are more than 10 centimeters, sometimes 8, and difficult localization, and more than 10 are contraindications. Pay attention with pedunculate fibroids, because sometimes you will have more risk, high risk to have adverse effects, because it moves around the screen, around the abdominal cavity. Absolutely not pregnant patients, and no abdominal scars, because it produces difficult able to see fibroids because of the ultrasound image. The patient has to be able to communicate with the doctor, and she has to be able to put in a prone, lying prone for more than 2 hours without moving. She has to collaborate, she has to understand, and at the end, she has no anesthetics complications. In the another characteristics of our fibroids, we know that if we use this classification, Funaki classification, we can reduce our fail rate. Type 1, hypo intensity, low signal intensity, like a skeletal muscle. We know that we will have a good Haifu response. Even on the other hand, if we have type 3 Funaki classifications, T2 MRI, with a high signal intensity, more than myometrium, as you can see, more wide than myometrium, we will have worse Haifu response. This could be another criteria to choose patients. Another criteria could be the grade of vascularization. If we have high vascularization, probably we will have poor response in a post-Haifu control. We will advise during the treatment, but we will check in a post-Haifu control. And if we have low grade of vascularization in T1 contrast MRI, we will find a good response of the Haifu treatment. This could be other criteria to choose patients for Haifu treatment. Okay, I finished my first part here, and now I'm going to continue talking about fertility. We must also take in account that the mean age of the first gestation is increasing. for this is the interest on Haifu and fertility, because we have 3 points, 3 important points that would be mean age of the first gestation is increasing in all the world, more in Western countries, but also I think all the world. These are numbers from Spain. As you can see, we are more than 32 years old to the mean age of the first pregnancy. The incidence of the uterine fibroids increases with age, and new IVF techniques allows pregnancy in older infertile patients. For these 3 points, we will find patients with myomas and who will ask us how to do with their fertilities. Focusing on these patients, with infertile older patients with fibroids, could we give some solutions? Focusing on, about myomas, there is a clear evidence that uterine fibroids as an independent factor can impair infertility. Also, submucosal and large intramural myomas, impact on the uterine cavity, decreased blood flow uterine cavity, and obstruct fallopian tubes. These 3 points could produce, giving consequence, low implantation rates, increased incidence of miscarriage, decreased live birth rates, and decreased pregnancy rates in comparison with women without fibroids. In this situation, we can do something. And we know also that small myomas impact negatively on IVF outcomes. And there is no high evidence in the literature to indicate routine myomectomy in fertilization techniques patients. Is Haifu an option? What do you think? Pregnancy complications are also known: premature delivery, placental abruption, placenta previa, abnormal fetal positions. Myomas gives big problems in our units, and we need to respond our patients with a high level of evidence. And if we recheck evidence, we know that gold standard nowadays is myomectomy. But the literature, there is currently a large arsenal of available treatments, but is still considered this one the gold standard for women with symptomatic fibroids who wish to become pregnant. There is evidence that surgery to remove fibroids improves fertility, especially in submucosal fibroids. Anyway, if you look at the literature, one wonders if that is really true. We have advantages that not for everyone, but in this recent review from Cochrane, they said that no high robust evidence for effect on miscarriage and pregnancy rates when we perform myomectomy in patients with uterine fibroids. Especially if you look at the literature, we could find more information about this point. For that, we have disadvantages: surgical morbidity, hemorrhage and blood transfusion, organ injury, and postoperative adhesions, as you know, that they could do, that could increase the risk of infertility and cause uterine scar, increasing risk of uterine rupture. Even all of this, we believe that myomectomy is a gold standard. Not easy to resolve. What about Haifu and fertility? What the evidence, current evidence we have? Haifu safety and effectively achieves selective ablation of uterine fibroids without damaging the surrounding tissues. After treatment, there is a gradual restoration of normal uterine anatomy. The myometrium conserves its biomechanical properties of tension and contractility and preserves ovarian and endometrial function. We have some studies that show no difference in anti-Mullerian hormones, preserves ovarian reserve, and that this study from 2020 that concludes that preserve endometrial function with the high level of evidence. What about evidence in Haifu and pregnancy? We already have several publications with good pregnancy outcomes after Haifu, series of 80, 100, and up to 130 pregnancy after Haifu with high gestational rates, but the conclusions of all the authors are always the same. Full-term pregnancy with a normal delivery and without complications are possibly after Haifu, and there were cases of uterine rupture or abnormal placentation. We need randomized clinical trials, but the evidence nowadays says this information. Our numbers in Barcelona. I'm going to briefly talk about our experience, Haifu technique and the pregnancy outcomes at Mutua Terrassa. One of our first patients treated got pregnant in April of 2009 and gave birth in January of 2010. Since that time, 71 pregnancies of 55 patients have been obtained with 43 live births. I have to point on out of the currently, our report constitutes the longest serious pregnancy after Haifu treatment in the Western country. Here you can see the characteristics of the patients. The mean age of the 55 women who become pregnant was 35 years at the time of treatment, was very high. More than half, 55%, were at least 36 years old, and 80% were nulliparous women. And we must highlight that 33% had primary or secondary sterility, and 80% had at least one miscarriage before Haifu treatment. It is reasonable to think that Haifu could help to improve fertility and this type of patients. Pregnancy outcomes. Our pregnancy rate is 34%. If we compare after laparoscopic or laparotomic myomectomy, we are in the same range, and after hysteroscopic, not, because you have that submucosal myomas has a very excellent successful rates. Excuse me. Among 71 pregnancy, we have 42 successful deliveries and 24 vaginal deliveries and 19 cesarean sections, 22 miscarriage. Remember the excuse me for the slides. Remember the difficult characteristics of high level of patients. 6 therapeutic abortions and 1 is ongoing nowadays. I need to cross to the next one. Just 1 second. Excuse me. Here, pregnancy outcomes, 42 pregnancies, successful deliveries after Haifu. The rate of full-term deliveries was 90%. Therefore, the rate of preterm deliveries was only 10% for cases, which is lower than series of that we know. But Ninalowo, doctor, has a very, very great numbers, and I congratulate you for your numbers, absolutely. And we have 3 kilograms of birth weight, and it should be noted that the series had a lower preterm delivery rate compared with the series with another Haifu studies. Intrapartum and postpartum complications reported 40%, includes 2 cases of placenta previa, 3 retained placenta, 5 abnormal fetal positions, 1 preeclampsia, and 2 renal colics. We have to note that no uterine rupture and no placenta accreta has appeared in our series. Okay, we finish with Haifu and fertility in our center. Now, a few words about adenomyosis. We know from different publications that adenomyosis is an important cause of infertility and that treatment is a great challenge for a gynecologist that we don't have so much alternatives. Adenomyometry is very aggressive for the uterus, and this type of surgery carries subsequent obstetric risks that we cannot ignore when we explain to our patients, and we have to be conscious that that could occur. In this, the results from this meta-analysis showed that after Hifu treatment for adenomyosis, a large effect was observed in reducing the uterine volume at 12 months, a significant reduction of dysmenorrhea at 3 and 12 months, and a significant improvement in quality of life at 6 and 12 months. Adverse reactions after Hifu were reported in 55% of patients, which were grade A or minor complications. Oh, excuse me, because it does not appear until now. The quality of life was reduced in the 6 and 12 months after treatment. There is still few studies on pregnancy outcomes after Hifu treatment for adenomyosis, but the results are quite encouraging. In this study, 68 patients with adenomyosis who wished to get pregnancies were treated with Hifu ablation. 54 patients got pregnancy at the median of 10 months after Hifu ablation, and 21 of them had delivered healthy babies. No uterine rupture during gestation or delivery, and the symptoms were reduced. In this other study from the last year, 93 patients with adenomyosis and infertility were included. 50 were treated by Hifu and 43 underwent laparoscopic excision. The most important conclusion of this study was the patients treated with Hifu showed significantly higher pregnancy rates and natural conception rates than those who underwent laparoscopic surgery. You can see here a pregnancy rate of 52% in the Hifu group versus 30% in the laparoscopic excision. 40% of natural conception versus 80% in the laparoscopic group. After Hifu, the average time from surgery to pregnancy was only 10 months. Okay, the last part of my lecture, I'm going to present some clinical cases. This is a little bit more easy to follow. A 30-year-old woman with no pathological history of interest, only one preterm birth, hypermenorrhea, anemia, and urinary symptoms, and sterility. We perform an ultrasound exam, and 10 centimeters transmural myoma, and MRI explains that it was hypotense and low vascularization. We performed Hifu treatment in 2 sessions. We could achieve hyperechogenic changes and changes in sonoview exam, and the contrast MRI after Hifu was more than 100%. Follow-up volume reduction up on 6 centimeters, and we perform an hysteroscopic myomectomy at the end. And here you can see a hysteroscopic diagnostic after myomectomy, and you could see the cavity here, the osteums, and 3 months later, she gets pregnant with a successful situation. Another case, here we present a case, 33-year-old woman. Here you can see this, excuse me, because I have now. Here you can see this myoma inside the cavity, different between different if compared with the other one, because this one is hypo in MRI, but high vascularization contrast MRI. We perform Hifu treatment. Here you can see MRI post-Hifu treatment. After that, 6 months, we reduce and we achieve a normal cavity, and 2 months later, she get pregnancy in 2 times in different situation. And this is another case report. It's a mode of, it's a point of because we want to explain that we have more indications of Haifu. We had been speaking about myomas and we speak about adenomyosis, but here we find a 30-year-old nulliparous woman who admitted at our center at 41.1 weeks of gestation for induction. She achieves a vaginal delivery, normal, with a live male boy, 3.4 kilograms, but we diagnosed a placenta accreta or increta because it was an unsuccessful attempt to remove the placenta from the uterus. We suspect placenta accreta. She was hemodynamically stable and no heavy bleeding, and she don't want hysterectomy. We could speak with her and her family, and they don't want hysterectomy. They want to expect and take conservative treatment, and we choose conservative management with the placenta in situ. 3 days after delivery, we could check the ultrasound exam. Here you can see the images and show a retained placenta around 10 centimeters near the uterine horn, right horn, and adjacent myomeasurement was less than 3 millimeters. MRI, retained placenta with myometrial infiltration that doesn't don't cross the uterine serosa. 1 month after delivery, we have the same situation, no changes in clinical or imaging changes appear. We propose Haifu treatment and she accepts. She didn't accept hysterectomy at any consult and she don't want to perform a surgery. Finally, the patient agreed with undergo Haifu treatment and we do a research before doing the treatment. And there is still few evidence on Haifu treatment in retained placenta accreta. Some cases have successfully been treated with this technique, like these 12 patients with successfully placental expulsion, conservative treatment, normal menstrual cycle, and 2 pregnancies achieved. We performed treatment, was long treatment with high energy. We achieved gray scale changes and ultrasound and MRI after Haifu. We achieve a non-perfused volume acceptable, ultrasound, and she starts expelled fragments from the placenta on several times, fragments between 1 to 5 centimeters with mild pain, not high, and little bleeding. And 4 weeks after treatment, the total expulsion of the placenta occurred. Patient had her first menstrual period 28 days after total expulsion of the placenta. And 1 year later, the patient achieved a full-term pregnancy that ended with an uncomplicated vaginal delivery. This case is only a curiosity case because we have only 1 case of placenta accreta treated with Haifu, and as you can see, there is a small level of evidence, and we have to be no exaggerate with this treatment. Okay, here the image of after treatment, and to conclude, due to it's a non-invasive. Uterine fibroids can negatively affect fertility and increase the risk of a specific pregnancy complications. Here appears the next one, I think. Okay. Myomectomy has some disadvantages that we should consider, especially in women who wants to conceive. According to our experience, Haifu ultrasound guide Haifu therapy is an effective and safe treatment based in our experience and previous studies demonstrating the ultrasound guide Haifu for surrounding myometrial tissue, ovarian, and endometrial function is safe. Patients undergoing ultrasound guide Haifu treatment of uterine fibroids and adenomyosis can achieve pregnancies with few intrapartum and postpartum complications. due to the non-invasive nature of ultrasound guide Haifu, seems to be the first therapeutic option in our center for women who have this gestational desire, and we have to take in account many advantages over myomectomy and uterine artery embolization in our center. In some cases, ultrasound guide Haifu could even improve fertility in patients with history of primary or secondary infertility. And maybe the most important one, we need prospective randomized studies to confirm these observations. Okay, thank you very much for your attention. Here you can see our Haifu unit in Barcelona. You are invited to come here when this situation is finished. Thank you very much.
Yes, thank you so much, Nuria. Yes, we will take that invitation once COVID, either we control it or we all get vaccinated. Yes, thank you. And I think this has been very, very illuminating. And we have many questions, many questions. I hope all the presenters are ready. I don't know whether the president wants to put in a word or so before we start asking the questions. The Sogon president has joined us. Yeah.
Yes. Thank you, Dr. Ajayi, and everyone. First, apologies for joining a little bit late. I had technical hitch, but I'm okay. I was able to listen to all the presenters. Can you hear me?
Sure, we can.
Yeah, okay, thank you very much. I was highly excited. I'm really pleased to have Sogon to be part of this. It's quite impressive to see that at the start, we had about 508 participants in the discussion. So this is a very topical issue that we have discussed today. And I thank all the presenters, Dr. Hugo, Dr. Nuria, Dr. Hamid, and on Christopher Aumakhu. Thank you very much, all of you. I think we have did a very illuminating presentation and some good challenges. I mean, in Africa, fibroid is a major issue. It is everywhere, but I think it's more in Africa where you see very large fibroids. And we all have before now relied on surgical intervention with all the dire consequences. But it's good to see new technologies coming up that are going to make life a little more comfortable for our patient and more better pregnancy rates. I'm highly impressed and I think there's a lot of learning here. And I can see many of the participants are asking if they could have some of the slides. I'm happy that Dr. Hamid has put up his link so that people can connect with him for embolization. Thank you very much. Sogon is very much pleased to be part of this venture. Thank you. Thank you, Dr. Jai, for organizing this. Thank you.
Thank you so much, President. Yes, so we go straight to the questions. Hugo, I think you will probably, I think I'll just make it free. So anybody can answer the questions, anybody on the panel. Will the Haifu treatment melt the fibroid? And will it come out through the vagina? That was one of the very early questions that we got. Did you hear?
Yeah. I'm sorry, I didn't have my microphone.
Okay.
So Nuria, you should answer that question. You have the experience with it.
I need to release on the question because I cannot understand exactly the question that they ask. Excuse me.
Okay. Will the Haifu treatment melt the fibroid? And will it come out through the vagina? That's the question.
I think that Haifu treatment can achieve to reduce, screen the volume, and sometimes if it grows to the submucosal cavity, they could appear from vagina, but sometimes it reduced to the uterine wall and it remains there. It depends on the major part of the uterine fibroid.
Yeah, thank you. So it depends on where the fibroid is. For submucous fibroid, it might get extruded from the vagina. Yeah. Somebody is asking, can Haifu be applied to endometrial polyp?
Could be applied, but I think that we have an alternative instrument. No, we have hysteroscopic assets, and for us it's easy, it's quick, it's better. I think we could achieve anatomopathological exam with from the tissue. Then sometimes it's useful.
Yep. Thank you.
I fully agree with Nuria. Of course, if you have a polyp, you shouldn't spend 3 hours for Haifu if you can do a hysteroscopic removal. And like Nuria said, quite important, with Haifu, you have never pathology. So if a fibroma will not be malignant, but a polyp could always be malignant. So I think Nuria is right. Don't touch, go for hysteroscopic removal.
Thank you. What time of the cycle should one do Haifu? Is there any particular time of the cycle that you should do Haifu?
No, it's not. It's not important the time of the cycle. Maybe she will be more comfortable after or pre-period, but it's not a point of contraindication to cancel the treatment if she had period or anything. No.
Nuria, would you do Haifu during the menstrual cycle? I know it's a stupid question, but some patients are scheduled and especially if you get their periods.
As I explained in my presentation, in Spain, it's difficult to put in a waiting list of the public hospital, and sometimes you have 1 day and one period of time to do Haifu treatments. If you have to change for this, could be a terrible situation, because maybe these patients could have to wait 1 month more, and sometimes if she had period, absolutely not. It's not a problem.
It's not a problem. Okay.
Yes. Okay. This is it's a tricky one, but it's a simple one. Is conception assured after Haifu?
Is conception assured?
That is the word.
Just so you know, that is a classic Nigerian question.
No.
You can't make that promise.
You can ask after microsurgical removal of a myoma. Is conception assured? Absolutely not. Huh? Nura, you agree? Yeah.
Yes, absolutely.
Yeah.
Yes, Hamed, this is for you. Can embolization be done on all fibroids, irrespective of size?
So I touched on this earlier, that the average reduction of the size of a fibroid is typically about, on average, about 50 to 60% after embolization when looked at 6 months to 1 year. So it's very important to look at the expectations of the patient. If the patient is coming in primarily with bleeding, we could do embolization on any fibroid of any size. We could kill any fibroid, but the question is, when you do kill the fibroid, can you get that reduction in size that you want? The patient will get symptomatic relief from the bleeding, but she might still have a big mass there. So it's very important to have those discussions. We typically try to shy away from fibroids that are over 16 to 20 weeks pregnancy size, because we do not achieve that significant reduction in size that women are looking for. But some women will not have surgery under any circumstances and still have fibroid embolization and are still able to get symptom relief from it.
Yep, thank you. Then this is another one for you. In patients with submucous fibroids using embolization, is there no risk of necrosis to the endometrium?
No. So it's interesting. I mean, we've looked at this. I mean, and a lot of people ask us, do you not necrose the uterus when you do fibroid embolization, because you're treating the uterine artery? So this has been very well researched, that when we use particles, for example, in fibroid embolization, we use particles that are over 300 microns. And we know that those particles preferentially go into the fibroid, and they do not go into the deep capillary network of the uterus itself or the endometrium. So the uterus stays alive, just like in Haifu, the pictures that were shown in Haifu. If you do MRI, post-uterine fibroid embolization, what you see is infarction of the fibroid with no enhancement within the fibroid, but the uterus itself continues to enhance, so it's not a problem.
Thank you so much.
May I add a comment, Mr. Chairman?
Oh, please do.
I'll go back about scheduling the treatment, the Haifu treatment. The problem is that in most of the centers, the same machine is used by different doctors and by different specialties. So the same machine is used by the urologist, the gynecologist, the oncologist, and all that. So that means the machine is scheduled for treatment all day long. So if a patient comes and she has her bleeding, she's on. So we have no time to send her back 500 kilometers because she's bleeding. The only thing what could be a problem is if you do the treatment in the second part of the cycle, you must be sure that he is not pregnant. I do not know what is going to happen if you do Haifu in a patient who is 10 days pregnant. I don't know whether Nuria has a statistic on that. What is the effect of Haifu on a beginning pregnancy?
We didn't find some cases about incidental pregnancy in our situation, because maybe for this kind of patients that we have, that most of them are infertile or looking for pregnancy or having problems with things, and we reduce the probability to have this problem. But we ask that they are sure that they are not in a pregnancy state with only a question. And sometimes if we have doubts, we can perform a pregnancy test, and absolutely this is a contraindication pregnancy situation, sure.
Okay, thank you so much. This is another question for Nuria. Can a patient have a repeat Haifu for recurrent fibroids?
Hi?
Can you repeat Haifu? Can you repeat Haifu after?
Yes, sorry, excuse me. Yes, we can repeat Haifu in maybe 2 or 3 different situations. We repeat Haifu if we cannot achieve all the fibroids that the patient has. Maybe she has more than 4 fibroids and we start from one part. And if we want to treat all the fibroids in the same session, we will give to her a high level of energy, high opportunity of risk of adverse events, and we have to prevent. As you can heard before, it's a long treatment. It's not short. It's maybe 1 hour, the shortest one, and maybe 3 hours, the longest one. She is asking for movement sometimes, and she needs to move. She's tired to stay in this position. It's a cold water, and sometimes you have to rest. Anesthesiologist said that she's arriving at the top of the comfortability, and sometimes you have to be carefully to don't produce some complications. Sometimes this is an option that you could perform a second session. Maybe another situation could be if we know that you will achieve more area in the second session. Sometimes you perform the MRI post-Haifu and you see a very clear zone, and maybe for something, for gas, intestinal gas, for intestinal gas on the bladder or something, you cannot achieve the other part of the myoma, and then you can do a second session if the first session was successfully. If you don't have any response, it's not a good decision to repeat, because it's difficult to achieve more good results if the first time you don't achieve good results. Okay.
Thank you. Yes, this is another one. Can Haifu be used for tubal blockage and peritoneal adhesions?
No.
I don't know if there is some literature about this, but it's the same reason that we don't use in very pedunculate fibroids. There is not, it's impossible to localize the tubes, no, by ultrasound in a prone position with no all the movements that you can do with ultrasound in abdominal position, and maybe it's not we have lots of risks, and it's not a optimal situation, sure, no.
Yeah, maybe we just say this, that Hifu is not used for treatment of infertility, it's used for the treatment of fibroids.
Yes.
And therefore, so if you have infertility, then you need to get the treatment for infertility. And then, because we actually, one of the problems we have is that the people that are responding to us, majority of them are patients with infertility. And so that's one of the things we're trying to let them see, that this is for treatment of fibroids. Infertility has its own protocol. Then
yes, I want to give attention the words that Dr. Hamed said before, that the expectations are maybe the most important part of the clinical attention, because if you give wrong expectations, sure you will fail in the process.
Yeah, it will backfire. Yeah, somebody is asking, is there anywhere consultants can go for Hifu training in Nigeria? Yes, you can. I'm sure by June in Lagos, you should be able to come for the training. But you just need to give us, tell us that you're interested in this, and then we'll see how that can be organized. This is probably, I want this to be the last one. I still have a lot of questions, but if we cannot answer all these questions, we would definitely answer them one by one, because I think the panel has been sitting for about 2.5 hours. I think it's just fair that we'll bring this to an end. So I'm 49 years old, had a child a long time ago, and I still want to have more. I was diagnosed with fibroid, but I'm scared of surgery. Can Haifu work for me?
I guess you need to repeat that question, because Nuria and I didn't understand exactly. Repeat it.
Okay, I'll say it slowly. I'm 49 years old.
Yeah.
I had a child a long time ago, and I still want to have more. I was diagnosed with fibroid, but I'm scared of surgery. Can Haifu work for me?
It depends on the case, sure. And today you have realized that you have some alternatives to surgery, and you can pay attention to them. You can ask to your doctor and put in a classification, and we will choose the better treatment for you, sure.
I'm just going to add to that answer. I think this is why it's very important that we're working all collaboratively with gynecology, the people doing Haifu, we're doing uterine fibroid embolization. As Nuria said, one of the things they look for treatment of Haifu is they look for hypervascularity in fibroids, right? And when you see hypervascularity, you say it's probably not going to work well. For us in uterine fibroid embolization, we love hypervascularity because we know that those fibroids are going to take up a lot of particles, which is why you want to be working with doctors who work collaboratively with other doctors to make those decisions for you, other than working in isolation.
Great point, Hamed. And that's why you're not far from me.
Yes, absolutely.
Anyway, thank you so very much. Chris, there's some questions I'm going to send to you.
Thank you very much.
Answer for us. But I think it's just fair that we bring this to an end. It's been a very exciting session, and I'm so glad that Hugo, Nuria, Chris, Hamed, that you were part of this. It's been so great. And we still have over 375 people, even 2.5 hours after we started. This shows you how important this topic is to us as a race and to us as a continent. Thank you so very much for being part of it. And then just smile, because I'm going to take a picture of you all just give me a smile, and then we will take a picture, and that will be the end. Thank you so very much. Bye.
Take care.
Thank you so much.
Yes.
Thank you.
Thank you so much.
Bye.
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 See you soon.
Yes, you're coming to
See
Lagos.
you.
You're coming to Lagos.
Anytime, but of course,
After the COVID era.
Corona, yeah, okay. So you will not believe me, I haven't been traveling the whole year now. Pardon?
I'm coming to Barcelona too.
Oh, it's
Yeah.
worth, I've been there twice, so it's very good to see.
All of you.
Thank you so much.